Let's think of the components of a puzzle. What comes to mind? Puzzles are perplexing, typically encasing a corner piece, a centerpiece, a side piece, and so on. Together, it makes sense, but alone, not really. And this brings up the biggest puzzle of them all, the brain. The brain is the centerpiece of our bodies, and we will start with the frontal lobe.
The frontal lobe is the most anterior area of the brain and has connections to the thalamus, basal ganglia, spinal cord, and cerebellum. It performs a variety of functions. It houses, amongst other things, the most advanced functions that our brain can perform, which include executive functions like planning, decision-making, and other forms of goal-directed behavior. These are located in the prefrontal cortex area. You can remember this because it is the furthest from the brainstem, which houses the most primitive functions. Clients with lesions here may have issues with impulsivity and may say whatever they are thinking, which can make for very interesting conversations. In 95% of people, the left side of the frontal lobe will have Broca's area, which is part of the left inferior frontal gyrus. A lesion here can result from a left-sided MCA stroke and will cause Broca's aphasia, which is when clients will know what they want to say but cannot express themselves. The motor cortex is the most posterior area of the frontal lobe and consists of the primary motor area, premotor area, and supplemental motor area. The premotor and supplemental motor areas assist with planning, organizing, and executing movement. The primary motor area sits in the precentral gyrus and is responsible for the initiation of voluntary movement. Its somatotopic organization forms the motor homunculus, where efferent signals are sent to issue conscious commands to the skeletal muscles of the body. The areas requiring more precise movement occupy larger portions. Lesions here cause contralateral muscle weakness, exaggerated reflexes, spasticity, and difficulty with movement.
The temporal lobe is located above the ears and below the frontal and parietal lobe.
Did you comprehend that? Let's rewind. That's what damage to the temporal lobe would look like. It inhibits the ability to comprehend language. The temporal lobe is located above the ears and below the frontal and parietal lobes. The temporal lobe is responsible for auditory processing, memory, language comprehension, and speech. Key cortical areas within the temporal lobe includes the primary auditory cortex, the secondary auditory cortex, and Wernicke's area. Damage to the primary auditory cortex may lead to the loss of sound localization or cortical deafness. Meanwhile, lesions in the secondary auditory cortex can result in auditory agnosia. Wernicke's area is located in the dominant hemisphere and is crucial for language comprehension. Lesions here can cause Wernicke's aphasia, which is characterized by impairment in language comprehension. OTs may refer clients to speech-language pathologists and audiologists if they suspect a central auditory processing disorder. OTs also work with clients who are hard of hearing or have hearing loss. Techniques for working with these clients include reducing background noise, using simple and expressive language, speaking slowly and clearly, asking the client to repeat directions, and using visual aids. Treatment options for hearing loss may include hearing aids, personal FM listening system, pocket talkers, and cochlear implants.
The parietal lobe is located near the back and top of the head, superior to the temporal lobes and posterior to the frontal lobe. The parietal lobe is involved with movement, orientation, recognition, and perception of stimuli, such as pressure, light touch, and pain. It is vital for sensory perception and integration, such as sight, taste, hearing, smell, and touch. An easy way to remember the overall functions of the parietal lobe is the 4 Ps: proprioception, pressure, pain, and position. The parietal lobe is important in occupational therapy because therapists can work with various sensory integration interventions and testing. This lobe is important for cognition, speech, and writing as well. The 3 main areas of function of this lobe are the primary somatosensory cortex, the sensory association area, and the posterior association area. First, in the primary somatosensory cortex, this area receives tactile information from the body, and lesions here will most likely result in some level of sensory dysfunction, which could be treated by an OT using various sensory integration techniques. Then, the sensory association area processes multisensory information. Lesions here will result in difficulty recognizing objects when manipulated in the hands, which will cause deficits in recognizing texture, shape, and size of handheld objects while learning. Lastly, the posterior association area is where visual, auditory, and other sensory pathways funnel for spatial coordination of these senses. Lesions in this area of the parietal lobe can result in associative agnosia, which is when someone can perceive and draw objects but will not be able to name them.
The occipital lobe is the smallest of the 4 lobes in the cerebral hemisphere, which is located in the back of the head and is responsible for visual processing. The occipital lobe consists of the primary visual cortex, also known as Brodmann's Area 17, and the visual association cortex. The primary visual cortex is the region of the brain responsible for receiving, integrating, and processing visual information relayed from the retina. Lesion to the primary visual cortex causes contralateral hemianopia, impaired visual perception, and difficulty recognizing objects, faces, and reading. Treatment for visual impairments depend on the specific deficits and may include rehabilitation strategies, compensatory techniques, and adaptive devices to improve functional vision and quality of life. Visual association cortex gives meaning to the visual stimuli. It plays a crucial role in object recognition, spatial perception, motion detection, and the interpretation of visual scenes. Lesion to the visual association cortex causes visual agnosia, which is the inability to recognize objects by sight despite intact vision. As OTs, we can help our clients with ADL retraining, environmental modifications like installing bright lights at home, increasing fonts on their electronic devices, and education.